Hello and welcome to the Crystal Podcast on iCode Media. Today I want to have the conversation that I was hoping Aaron Warner and Hardeep and Walt and Roger were going to have with the Prokera Slim versus the Cam 360. I was really wanting a battle. I wanted them to dig in and take sides and kind of steelman each argument. Now, the reality is that both Hardeep and Walt are they are reasonable clinicians and they're nuanced clinicians. But I wanted a real point and counterpoint. And I thought Aaron set it up really perfectly. You can go back and listen to the episode. I don't need to recount who said what and what people said. I think it's really worth your time to go and listen to it because you do get a lot of clinical nuance. And I won't tell you where my original position was, and still largely is, although, like any good conversation, my mind gets a little bit more nuanced as I'm listening to the discussion. And that's kind of obviously that is what I wanted to get out of it, is to view the other side. But the point here is not to really, for me, I do not want to kind of sway you in what I believe is the better of the two. I do have a belief, and that belief, as you've heard me talk about on here, it's a lot of times grounded in. I hope it's grounded in evidence, but the question I always struggle with is my belief actually grounded in current evidence, or am I stuck someplace? And so, you've heard me talk a lot about the scientific method. You've heard Kyle Kluge talk about it. He's written about it recently. And I say all that to say what I really wanted to hear was, let me take this position and let me take that position and let's steelman each one. And when people are reasonable, it does help us sway, but it doesn't sometimes get to the heart of why one might be better than the other in certain cases. So, obviously, what's inconvenient is if I'm trying to create a strong debate, or what I wanted Aaron to do, and I think what Aaron wanted to do was to create a strong debate where Hardeep might say something like the Cam 360 is the answer for everyone, right? She didn't say that. She said, there's patient selection. She talked about milder stage 1 neurotrophic keratitis. She talked about waxing and waning, persistent epithelial defects with reduced corneal sensitivity. She talked about patients who tried Prokera Slim and weren't eager to do it again. Surgical glaucoma patients with blebs and tubes and trabs, and, the ring might not be the answer. And, Walt didn't say Cam 360 has no place. He said that he trusted Prokera for years and that he hadn't had major problems with the ring because patient education matters. And also that he was challenging himself to use the Cam 360 enough times to fairly evaluate it. I believe in the episode he said, use it 25 times and see what you think. And, it's very Walt. It's very practical. It's clinically grounded, and it's very mature. And then obviously Roger, he had the unbelievable, job of kind of like, let me show you where the company has thought about this and where he was trying to answer, or the company's trying to answer, where clinicians are, poking at products or, trying to figure out where each might be useful. So again, those explanations were important. And the point is that, the Cam 360 wasn't created because Prokera stopped working. It was created because doctors had identified a real barrier. And to BioTissue's credit, they responded, right? And so that Cam 360 was designed for another delivery mechanism for cryopreserved amniotic membranes, where comfort as a central design goal was also applied so that patients can get some benefit to a cryopreserved membrane. Now, the reality is that there's a trade-off, right? The Cam 360 may be more comfortable, but it might take a little bit more time to assemble that for the patient than just placing a Prokera. And so that, that's nuance. It's good. But that's not the fight I wanted. I wanted something different. And so today I'm going to do something that Aaron was trying to tee up. It's not Aaron's fault. It's the reality of good clinicians in the room who aren't willing to indulge in taking one side versus the other. So I want to force the debate. So if you had to pick one and you were going to order a number of these products for your practice and you can only use one, would it be Prokera Slim or would it be the Cam 360? Could you defend that position? Not casually, not with, I kind of like it, or not, my rep is nice, or not, Mrs. Jones liked it and Mrs. Jones might be wonderful, but she's the clinical equivalent of, a pop-up weather storm, a pop-up thunderstorm. It happened actually right outside of Tennessee, outside of Nashville on my way home. We get some pop-up thunderstorms we got to deviate away. And I can't figure out what the weather pattern was. There was no SIGMETs. I'm sorry, I'm getting off topic. But the point is that, Mrs. Jones is just like that. It's an N of 1. The most common questions I get include, what ophthalmological codes or evaluation and management codes should I use? What ICD-10 codes do I need to bill with this CPT code? What CPT codes can be billed together and what can't? And my favorite, how do I manage a patient who has diabetes who comes in for a quote-unquote routine eye exam? These questions really highlight the confusion and uncertainty that serves as a daunting hurdle for providers, makes it more challenging for them to care for their patients and provide those patients with the best opportunity for a lifetime of ocular health and clear vision. That's why we built iCode Education, for this specific purpose. Our mission is to provide optometrists with resources to help you understand disease states, revenue cycles, and billing and coding so that you can put that on autopilot and truly care for your patients. Check out iCodeEducation.com. That's EYECODE education.com. We've developed a premier billing and coding bundle that includes all of our billing and coding resources in one place. We also have a 10% discount code just for listeners of this podcast. Enter the coupon code EYECODEMEDIA22 at checkout. We'd love to work with you. Check out iCodeEducation.com. A question that I hear all the time is, should I be taking an AREDS 2 vitamin? With MacuHealth Plus, we can finally have a formulation that follows science without adding unnecessary ingredients, and we can rely on it to know what is in the container is actually what is labeled on the container. We use it specifically for intermediate AMD patients, and the patients with AREDS 2 data it's the strongest for. And the ability to include mesozeaxanthin allows us to support macular function, not just slow disease progression, although it's good at that. That's why it's become a go-to in our clinic. So can you defend it philosophically, clinically, operationally, financially? That's the exercise I want to go through, and I think it's a useful one because the real debate isn't just about CAM 360 versus Prokera. The real debate is what we value most when we manage ocular surface disease. Do we prioritize maximum therapeutic certainty, even if the treatment is less comfortable, or do we prioritize earlier access and patient acceptance and possibly even doctor acceptance, right? Am I willing to actually do it more often for the benefit of the patient because I'm more comfortable doing it, even if the treatment requires a little different workflow, and even if it may not be applicable to as broad of a patient population? And that's the conversation below the conversation that I really wanted to rise to the surface. And so again, this isn't me saying, I mean, actually the conversation that Aaron had was probably the conversation I needed to hear, but what I wanted to hear was this. And so that's where I want to take this. So if we're going to take the Prokera Slim only argument, let's treat serious diseases seriously. If I were going to build the strongest possible, we'll call it the Walt style Prokera Slim argument, I would start with this central theme. Do something. But I would sharpen it a little bit. I would say do something serious. Walt's point wasn't that every patient needs Prokera. His point was that when we are looking at a significant ocular surface disease, something like persistent staining, neurotrophic keratopathy, we can't behave as though another drop sample is automatically the highest form of intervention. At some point, The cornea isn't asking for us to be sympathetic. And in fact, the patient really isn't. They're asking for help. And the Prokera Slim only argument starts with that premise. The ocular surface and ocular surface disease is not primarily a comfort problem. It's a healing problem. And that is important because in optometry, we're sometimes a little too good at making pathology sound adorable. We might say something like, well, you have a little dryness, or your surface is a little irritated, or let's try some drops. And sometimes that language is appropriate, of course, but not every patient needs a dramatic speech or a three-dimensional model or a, something like that. But sometimes the cornea is not a little dry. Sometimes it's sick. Sometimes the epithelium is breaking down. And sometimes those corneal nerves are not functioning properly, and that surface has failed these kind of polite, gentle therapies. And the patient has already used artificial tears and anti-inflammatories and steroids and plugs and lid treatments and compresses and, whatever else we've kind of given them to try to palliate the problem. But the cornea is still sick, right? And so at that point, the Prokera only advocate would say, stop negotiating with the disease. If a patient has a diseased cornea that needs cryopreserved amniotic membrane, then the priority shouldn't be about making the treatment feel invisible. The priority should be, let me give you the maximum healing possible. And Prokera's materials lean heavy into that identity. Actually, if you read through a lot of their brochures, it describes Prokera as a biologic corneal bandage, as helping empower the eye's healing abilities and creating an environment for regenerative healing. It emphasizes that Prokera contains, obviously, cryopreserved amniotic membrane tissue, supports restoration of healthier epithelium, reduces inflammation, and then improves corneal health and helps minimize the risk of scar tissue formation, which is the first part of the Prokera-only argument. It's the identity. The Prokera Slim knows exactly what it is. It's a self-retained therapeutic device built for corneal healing. And that clarity adds value. When I treat moderate to severe ocular surface disease, neurotrophic keratitis, and RCE breakdown, corneal ulcers, post-surgical ocular surface diseases that become small, events that can actually become more significant over time, I want to say this is the treatment. This is the medicine that we're using. And the second part of the Prokera only argument is legacy, obviously, the legacy of Prokera, which has been around for longer than I've been in practice. It's more than 20 years of clinical performance, more than 300,000 transplants, and like 350 some peer-reviewed publications. Prokera maintains a structural integrity that we know exists. It's associated with corneal nerve regeneration and ocular surface healing, and that history is important because it gives you the confidence to know I'm doing something that will be impactful. Not that new products don't have that, not even that the CAM 360 can't by extension be applied to that, but we just don't have as much, we don't have as much actual data behind it. And so we have to think, all right, well, new products are how medicine improves. And so if we never adopted new products, half of us would still be treating everything with artificial tears and, hey, everything's going to be fine. But if we're choosing only one product for the practice, that legacy would matter if I were steel manning the argument. A product with a long track record gives us confidence. It gives our staff confidence. It gives referring providers confidence. And it gives us the language when we're explaining the treatment to the patient. We can say we're not experimenting here and we're not dabbling here because it's more comfortable. We're using an established therapeutic device designed to help your cornea heal. And there's lots of evidence behind it, and I think that's powerful for the patient. The third part of the Prokera only argument is the procedural simplicity. I know that a lot of people think it's more challenging to insert, but the reality is if you've done it a couple times, it's easy. It's easy to do, and I think sometimes that matters more than we might admit. If we pretend that every decision is purely biological or purely historical, we talk about cytokines and epithelial remolding and nerve density, and we talk about inflammatory processes, and they do matter. But the reality is that if it's really easy for me to grab out of a case, rinse off, tell the patients it's going to burn, stick it in their eye, tape their eye after they're, anesthetize them, stick it in their eye, tape their eye, and tell them it's going to work. I mean, that's pretty easy. I mean, the amount of time that it takes me as the physician to actually insert that is less than 5 minutes after. If I'm doing all those tasks and my tech is bringing all those things to my office, it just doesn't take very long. And real clinics have full schedules, and real clinics have technicians that are learning, and real doctors running behind because, our glaucoma patient showed up late and they were cantankerous when we're trying to get a visual field test. And, so the point is that, we get behind. And so this efficiency matters, and Prokera Slim obviously is self-retaining. It's already assembled. Its comparison sheet lists a design that has easy insertion, full limbal coverage as advantages. It's not a minor operational point. That ring is often discussed as a drawback for us in terms of comfort. But it gives us, the ability to know that it's covering all of those areas. It's not just a flaw. It's the delivery system. It allows that amniotic membrane to spread over the entire surface. And that, I think, is important if you're thinking about applying those benefits to the entire surface. It's predictable. It creates a straightforward procedure, and it's simple for us to explain, insert, and build into our clinical workflow. And so we don't have to pretend the ring is comfortable. We know it's not going to be that comfortable, but we just have to argue that comfort isn't the highest value in that moment. That leads to the fourth part of the Prokera only argument, and that's patient seriousness, which Aaron hit on, I think, during the episode. It's the part that we don't say loud enough. And sometimes the treatment burden has educational value. And I'm not advocating for unnecessary discomfort for patients. It's not like medieval, but there's differences between unnecessary discomfort and meaningful treatment burden. As Aaron described in the episode, the cast isn't comfortable. Colonoscopy prep isn't anyone's favorite plan. When I get, I've been very blessed with my teeth, but dental work isn't described as a refreshing spa-like experience. I mean, as much as dentists try to make it that way, it's just not. But patients accept those burdens because they understand that something clinically important is happening to them. And I would say that the Prokera Slim only argument says the same principle applies here, is that when I put a Prokera Slim on a patient's eye, the patient knows we're doing something serious and they feel the treatment. So that might actually cause them to, if they, in so much as they can, right? It might have them take their next, after you remove that next phase of treatment more seriously. They live with that treatment for several days. They understand that it's not just another drop, another sample, another suggestion that's casual. It's a procedure. It's a treatment. It's us saying your cornea is sick enough that we need to intervene. And that change in communication can change the patient's entire psychological framework. They don't think about dry eye as an annoyance. They start thinking about ocular surface disease as a medical condition that really matters. Because one of the great failures of ocular surface disease care is that we often under-communicate the severity. As I've said before, patients hear dry eye and they think chapped lips. We know ocular surface disease can involve inflammation, tear film instability, epithelial compromise, MGD, toxicity from medications, neurosensory abnormalities, surgical disruption. I mean, but the patients don't always know that. And sometimes they need us to be clear, not cruel, but clear. And, your cornea is sick. Your eye is sick. That phrase came up in the discussion, and I think it's important, especially if you're making a Prokera only argument. It's not dramatic, it's accurate. And once you say that to patients, the Prokera Slim makes sense. You're not putting a ring on the eye because the patient had mildly inconvenient dry eye today. You're doing it because the cornea needs help healing. And I think the fifth part, so again, if I'm steel manning this, I would say the fifth part of the Prokera only case is the disease breadth. The Prokera, has a wide range of applications, including corneal ulcers, neurotrophic keratitis, exposure keratitis, punctate, keratitis filamentary. You can go on and on and on. Even down to Stevens-Johnson. The breadth matters because if we're only picking one product, and I can only stock one cryopreserved amniotic membrane option, which actually I don't know the answer, but my guess is that BioTissue knows that certain practices will only stock one, or they largely use one. So if I were making the argument for Prokera only, I would say I want the one that can go wider and deeper. I want something I can use when the patient has dry eye related staining that's persistent, and also when the disease is more advanced. I want something that I can reach for when I'm managing neurotrophic disease, delayed healing, epithelial compromise, RCE, ulceration, etc. And the Prokera only advocate would say the CAM 360 may be attractive for earlier, more superficial disease, but if we are standardizing around one product, and that's probably a reality, one that Roger didn't bring up, but I suspect exists, why would I choose an option that's designed for just the milder end? I can't even touch the bigger stuff. So why would I choose a product built around comfort when the hardest cases, the ones I really want, I need the most confidence? And so that's kind of the hardline Prokera Slim position. Don't build your protocol around the easiest patient. Build it around the patient you're most worried about, because in our practices, the most dangerous failure is rarely over treating the mild cases, which would be fine to use a Prokera Slim on. The more dangerous failure is under treating the severe ones. And, the sixth part is billing, documentation, and medical necessity. And really, I know people kind of feel overwhelmed, and less emotionally available, but billing and coding is where enthusiasm, is basically just sitting, because there's the questions of, do I use another 99 code? And is there a post-operative period? And what if it doesn't get paid? And is there a prior authorization? And so, my bottom line is good care is going to be well documented enough that it will survive a scrutiny under audit in the real world. It's not just enough to know that you did something. You have to write it down, and you have to document the staining. You have document the failed therapies and the reduced corneal sensitivity and the diagnosis. You got to document the diagnosis appropriately. The medical necessity, the amniotic membrane, why it was important in that discussion. Hardeep did emphasize the testing corneal sensitivity and documenting whether or not sensitivity is normal, reduced, or absent, as Walt emphasized that persistent epithelial staining, despite appropriate therapy, should raise a suspicion of neurotrophic keratitis. Parents often ask whether a daily disposable lens can really slow myopia progression. Well, with MiSight One Day, the answer is yes. And that's why it's one of our most used options for our young myopes. Kids adapt quickly, comfort's excellent, and compliance stays high because it's a daily lens. In my practice, that reliability is what allows us to confidently build long-term myopia management plans for our patients. Check it out for yourself. MiSight One Day. If you're ready to stop feeling overwhelmed and start running a safer, more profitable practice, here's the next step. First, book a strategy call with us, Practice Performance Partners. We'll uncover the biggest risks and opportunities in your practice. Then, choose the package that fits your goals. From there, we'll get you launched with confidence, with clear systems, with expert support, and with peace of mind, knowing your practice is protected and set up to grow. Don't wait until something goes wrong. Book your strategy call with us, Practice Performance Partners, today. And that documenting that corneal sensitivity helps you justify why and when you intervene. And really that matters for either product. I mean, it matters for either product, but the Prokera Slim only advocate would say that Prokera fits more naturally into this because it's clearly medically necessary. Because it's more obviously a procedural intervention, in some people's minds, and if I were making the case, I would make that case for a clinically significant corneal problem. And the patient experiences it as serious. Our team experiences it as serious, and most of the time the charts will too. And so if that medical necessity is there, we shouldn't be afraid of it. And it connects to the broader identity of optometry, which is patients are better served when optometrists practice to the fullest extent of our knowledge, education, and training. Practices are more stable when they build systems around real medical care rather than simply detecting the disease and referring it away. And in the Prokera Slim argument, that fits into that identity. It says if we're going to act like a medical eye care provider, then we're going to act like one. We don't apologize for using a therapeutic device. We don't apologize for when treatment is uncomfortable. We might acknowledge it. We don't apologize when a patient needs to come back for follow-up. We don't apologize because the chart needs documentation. It's just part of the job. And so the Prokera Slim only position can be summarized this way. We use Prokera Slim only because it is the more established, more efficient, broader spectrum, clinically serious option. It's had a long track record, clear therapeutic identity, and self-retaining delivery system that supports predictable placement and full limbal coverage. If a patient is sick enough to need cryopreserved amniotic membranes, they're sick enough for the product that maximizes therapeutic confidence. I think that's a strong argument, and it's not subtle. It's clear. It's strong. And I think that summarizes kind of the position I was hoping somebody would have taken. I think that's, if I were going to go through all the points, that's the position. Now, I want to switch sides. I'm going to strongman the CAM 360 only argument, which is basically like, let's intervene earlier and remove as many barriers as possible. And if I were building the strongest part possible, we'll call it Hardeep style CAM 360 argument, I would argue this. The best treatment is not the one you admire. It's the one that the patient can actually receive, tolerate, and repeat, which isn't a comfort argument. It's an access argument. And honestly, I would actually say that if it's the case that more doctors will intervene earlier because they have this as their primary option, then that might be probably the strongest argument, is that if the doctors are less intimidated by it for whatever reason, then the patients will receive the benefit earlier, right? And I think Hardeep's comments were important because she didn't describe the CAM 360 as the comfortable option. Actually, she described the patients who can fall through the cracks of a Prokera only mindset. You know, like your milder stage 1 NK patients with reduced corneal sensitivity and that waxing and waning SPK, or patients who already tried Prokera and didn't want to do it again. You know, again, the patients with blebs and tubes, she talked about that. So it reframes the entire debate. And the CAM 360 only argument begins with a different premise. Access is not a convenience issue. It's a clinical issue. And because of, if a treatment is theoretically excellent but practically delayed, avoided by doctors or patients, refused, removed, or feared, the patient doesn't receive the benefit at all. And a treatment the patient will not accept is not a treatment plan. It's just hopeful. And so that's a pretty strong argument. I'd say the CAM 360 advocate looks at Prokera Slim and says, I understand the history. I understand the clinical performance. I understand the ring. And that's the problem. That ring may help retention, but it may make placement easier. But it makes the treatment feel serious, yes. But the ring also creates resistance, both by the patients and by the physicians. You know, patients might dread it. Physicians might dread it. Patients, you know, might have regretted using it in the past because it was so uncomfortable for a handful of days. And so, you know, that's important. I think some patients might just be anxious enough to say, are we going to go put another ring on my eye? Because their soul, you know, they're quietly, you know, just avoiding that as an option. And so the CAM 360 only advocate would say, why are we building our treatment model around a barrier? Why not just remove the barrier? And so the CAM 360 was developed, obviously, to optimize the comfort. The product sheet describes a ringless, fully hydrated, self-stable cryopreserved amniotic membrane that can be placed underneath a collagen shield or a BCL. And the same sheet talks about the power of the cryopreserve, again, hearkening to the history of the Prokera, right? Where it's saying, listen, you can apply these data points to this new thing, which may or may not be clinically and scientifically sound, but it is, there are some logical leaps that we can, or steps that we can make in that case. The heart of the CAM 360 only argument is it's the same thing, just for earlier intervention. The same therapeutic category, with less patient resistance. And I think that point is made directly. I would say that dry eye is a progressive disease that lacks options, and that lack of option to make it an option earlier in diseases force physicians to wait to intervene till the end of the road. Now, obviously when you think about step 1 through 4 therapy in terms of Due's stepwise approach, amniotic membranes exist in step 4, but that kind of falls off it's sort of, you can throw that step therapy when you have persistent epithelial defects and or neurotrophic keratitis, where you're treating something beyond simply dry eye. So again, I think that the point is that when you approach it that way, that's just a feature, right? It's a treatment philosophy. And the CAM 360 only advocate would say, we've been waiting too long if we wait until that patient has failed everything else, until the staining is bad enough, until the patient has suffered enough, until the cornea is feeling nothing, right? Like that's what they would say, is like, that's good clinical judgment to do it earlier than to wait till later. So maybe that is the hesitation of us, right, as clinicians. But if dry eye is progressive, and if stage 1 neurotrophic keratopathy can be subtle, and if persistent epithelial defects can represent more than just dry eye, then early regenerative intervention makes sense. Not after everything else fails, but earlier. Not when the cornea has already, become super compromised, but earlier. So that's where I think the CAM 360 becomes compelling if I were going to make that argument. It's the barrier to earlier amniotic membrane use has been the ring, and a ringless option changes that conversation and allows us to say, we can intervene now. And I think that's really important. The CAM 360 will list applications, including mild to moderate superficial punctate keratitis, dry eye stage 1 neurotrophic keratitis. And it states that obviously cryopreserved membranes have been present for a long time to reduce signs and symptoms of dry eye disease, corneal staining, promote epithelial nerve regeneration, and that can happen super quick, right? In a couple days, 2 to 3 days can happen. And the second argument obviously would be timing. So the second argument I would make as a CAM 360 only argument is not trying to win by me being more dramatic, but being earlier. It's different kind of power. And we often can celebrate rescue, a 3+ corneal staining that goes down to trace, or in an advanced case of corneal ulcer that's healed, because we were able to kind of come in and be the hero. But, in chronic disease management, what often is easier to solve, and we know this in glaucoma and we know this in macular degeneration, and really we should know it in dry eye, but oftentimes because we associate symptoms with how aggressive we're going to be as physicians, then we often will not treat dry eye the same as glaucoma and macular degeneration. But we don't have to be a hero in this either, I guess is the point, right? You can't be a hero in glaucoma or macular degeneration, but in dry eye, sometimes we think we can be the hero. But I'll tell you, it's a lot easier to manage the easier cases and prevent them from falling off. And so if I were going to make the CAM 360 argument, I'd say the best medicine in this case isn't rescue. It's preventing rescue from being necessary. And I think the CAM 360 only advocate would say Prokera Slim is built for a world where amniotic membrane is something you reach for after the disease is so serious that you can justify the ring. CAM 360 is built for a world where amniotic membrane becomes part of an earlier ocular surface disease management, which is a different model. It's a more chronic disease model, actually, than an emergency intervention. And so that would speak to, again, not telling you what my side of this is, but that would speak to my, my chronic disease approach to comprehensive eye care. And I think optometry does need to keep moving toward chronic disease management. We can't keep treating ocular surface disease like a series of disconnected flare-ups, because it isn't. It is chronic. It's progressive. It's multifactorial. And many patients, they've tried lots of different things, and they're continue to be defeated. So The important part is that, the CAM 360 advocate asks, if we all know the disease is progressive, why would we choose the product that patients are more likely to delay and physicians are more likely to delay, and not choose the product that lets us intervene sooner with less resistance? I think the third part of the CAM 360 argument is patient acceptance. And sometimes we talk about comfort as though it's soft, but almost like comfort is for spas and not clinics. But comfort isn't soft. It drives acceptance. It drives adherence. It drives outcomes. And so patients who won't repeat a treatment, you can think about just like using your prescription medications, right? There are different prescription medications that will burn more than others when they put them in. And we might be more resistant as clinicians, and patients might be more resistant to those treatments if they're less comfortable when they use them. So a patient who won't repeat a treatment is not successfully managed when we think about treatment adherence. If they delay treatment until they're miserable, then they're not optimizing their care. A patient who hears we need to put a ring on your eye for several days immediately decides they'd rather not do that. That's not just a luxury, it's a strategy. And so, when we think about, we're trying to optimize patient comfort and earlier intervention, that I think is a really legitimate point to kind of have. That's the thing I would harp on if all I could use were CAM 360s. And I think that, we're lowering the threshold for the real care for the patient. And I think that's important. Now, the fourth part of the CAM 360 only case would be repeatability. The ocular surface disease isn't always one and done. And so that should be something that we really think about in terms of chronic disease management. Patients with dry eye disease, neurotrophic disease, glaucoma medication, ocular surface issues, and chronic inflammation, they need ongoing management. They'll need repeat interventions. You know this if you do IPL. You'll know this if you do punctal occlusion or LipiFlow or pick your other poison. They may improve and then regress, and they improve and regress. They stabilize, they flare up, and, allergy season, cataract surgery, they start using a CPAP, that all kind of enters in. They might get conjunctivitis that tilts them out of balance. If you've seen a lot of ocular surface disease patients, you will see these patients that do really well for years and all of a sudden something flares up. And those treatments need to be repeated. Some of them will be amniotic membrane treatments, and that patient experience matters because if the intervention is easy, they'll tolerate it again in 6 months or a year or 2 years. They'll say yes when it has to be. They won't keep delaying and making their experience worse because they're worried about the next thing. So I think that CAM 360 advocate would say, build your model around the chronic nature of the disease. Choose the option that patients are more likely to accept again. It's not a weakness. It's just a reality. I think the fifth part of the CAM 360 only argument is practice integration. We often think of integration from the doctor's perspective. How easy is it to insert? How long does it take? How do we train staff? How does it fit into the schedule? And those are questions. And I think, to be fair, Prokera Slim has a strong argument on that simplicity. I made it when I was steel manning the Prokera Slim only. But even Prokera, Roger from Prokera, admitted that in his discussion that CAM 360 may be more comfortable, but it's more tedious to assemble than simply placing the ring. But I think the CAM 360 has a different integration advantage, storage and availability. It's shelf stable, it's room temperature. And when we think about that, we think, listen, I can build a protocol around how to insert this. And as if I'm doing a multiple of these over time, it becomes easier and easier, which it becomes more practical. And practices build these systems. So these systems improve when we reduce barriers. I don't have to have, all these other things around. I can make it simpler to insert. Easier to store, easier to make available, easier to reach for when the opportunity presents itself. Well, then maybe I'll use it more consistency in my practice, and that can be delivered then to the patient. It's if I have a treatment that's theoretically available but operationally inconvenient, I'll probably underuse it. It's not because we're bad. It's because, we're humans in clinics and humans are humans, right? So if we want a treatment to happen, we have to make the process frictionless. So I think you can make a case there that if you build a process around making that as streamlined and simple, it'll probably feel very similar to the Prokera Slim insertion. If I were going to make a 6-part argument for the CAM 360, it's that, it's the same, right? I would say it's the same science as the Prokera. The core biologic, what you're getting on the surface is the same. So maybe you use it earlier. Maybe you can't use it for the really bad stuff, but let's be honest. Most of us aren't going to see the really bad stuff. So, we don't have to argue about, I would say it doesn't matter, right? I can apply that. I'm not saying it's dehydrated versus cryopreserved. I'm saying, listen, it's a cryopreserved amniotic membrane. We're just removing the barrier. So you can maybe apply more of these studies to it. That's the argument I would make if I was a CAM 360 only. I would say there's the matrix is the same. It's still fresh and cryopreserved. It's, same therapeutic benefits. So I think that's important. I think that's important if I were going to make that argument. And I think that's a bridge, right? It's a scientific bridge from the history to something new. And it's not saying that it's comfort instead of biology, which is what a lot of times people would say with a dehydrated membrane. They're saying it's comfort and the biological advantage, which is earlier intervention and earlier access. And I think that's a stronger argument than just saying patients like it better, which is kind of what I heard in a lot of cases for. In fact, it's a reality for the older dehydrated membranes that we might be using. So I think the bottom line is bringing in this as an option. It allows me to make that case if I were going to make it. Patient preference alone isn't enough, but patient preference aligned with biology allows us to intervene earlier, and I think that's a strong case. The 7th part of the CAM 360 argument, I think, is philosophical, and it's built around the idea that we shouldn't wait for disease to become severe before we intervene meaningfully. And I think that would be a case that would speak directly to me, as I said before. And so we should capture the disease earlier. We should educate better. We should document more clearly, build the care around pathways that manage patients before they fall off a cliff. And in my practice pillar model, we talk about moving from a detect and refer to capturing care and managing that patient. Each patient need can become a pillar of the practice, and taking care of the patient becomes taking care of the practice. And that model emphasizes things like intake forms, clinical protocol, patient education, billing and coding processes, and staff training around each pillar. And I think that if I were making that case to speak to the Chris Wolfe pillar builder, I would say that CAM 360 might fit in pretty well there. It can be built into a dry eye pillar. It can be built into an earlier stage 1 neurotrophic keratitis pillar. It's a regenerative treatment option earlier in the disease process. You'd also, though, have to convince the Chris Wolfe that if you're only going to have one thing and you're building a pillar that allows you to flex outward to take care of more of those things in that one pillar, you might fail with the CAM 360 option because it's a little bit more limited, right? It gives the doctor, but it does give the doctor a way to say, I'm not just chasing symptoms, we're treating the ocular surface earlier in that pillar, and that might allow you to build the pillar more confidently. Many dry eye practices, as I said before, are too symptom driven, and I think that they wait for the patient to complain loudly enough before they respond. And a better model when we're building pillars is disease driven. Look for staining, look for risk factors, look for corneal sensitivity, MGD, which isn't really applicable to here, but it absolutely is an underlying driver for a lot of these things. Document the failed therapies, explain the condition, offer the treatment. Don't wait until the patient looks beat up before you offer something that the patient can actually benefit from. So I think the CAM 360 only position could be summarized this way. Use CAM 360 only because it preserves the benefits of cryopreserved amniotic membrane while removing the ring, improving comfort, and lowering patient resistance and doctor resistance, enabling earlier intervention, supporting repeat treatment, simplifying storage, and expanding access to regenerative therapy. If dry eye disease and stage 1 neurotrophic keratitis are progressive conditions, the best product is the one you can use earlier, more comfortably, and more consistently, which I think is also a very strong argument. And so now we have a real debate. what Aaron actually set up. And it's why I appreciate Aaron's original frustration. He wanted a point counterpoint. He wanted somebody to take a position, and I understand why. I wanted it too, because the nuance is clinically correct, and it's absolutely the conversation that should have been had, but sometimes it can be mushy. I think a strong position forces us to clarify our thinking. It makes us say what we value and what is useful. And Aaron's own bias in the conversation was clear. He had more confidence in the Prokera. He liked the efficiency. He liked the seriousness of the treatment. He even made the point that discomfort has a psychological value because it communicates to the patient that the disease is serious. And I think that's a clear clinical philosophy. And not every treatment should be invisible. And sometimes the patient needs understanding that we're intervening because the disease warrants it. But Hardeep's response gives the counterweight. She didn't reject that seriousness. She simply showed where Prokera Slim may leave gaps. And patients with milder NK, reduced corneal sensitivity, would be better earlier. And I think that's important. And so really, when I go through this whole thing, I'm way more softened to the idea that maybe I do need to have two options in my practice. And I think it really underlies the bigger issue is that the debate that I listened to, or the discussion, the clinical nuance discussion that Aaron led, was really worth having. And now as I try to clearly delineate the only case for either of those options, I kind of find myself even more toward the middle. Do something, use something, and then expand out. Pick one that you want to start with, get comfortable with it, and then see where you're failing in that, or you're not making it available to your patients, and then try the other as well, right? So I think that's really helpful. And I think it's really useful to say there's clinical nuance. What I don't want you to do is nothing. And sometimes when we're uncertain and we do both at the same time, we wind up doing nothing at all. So I would say pick a position, pick a side, start there, and then where you're seeing failures or places that you can't use the one that you pick when you need it, now bring in the other one. Because the bigger failure isn't choosing the wrong membrane, actually. The bigger failure is not recognizing the disease. And I think one of the most important parts of the original discussion really had very little to do with that debate itself. It was more about neurotrophic keratopathy. And I think that more importantly, when we talk about how often we miss it, we still think it's like this dramatic end case or end stage cornea that looks terrible. It's not. And so that's really what I think is helpful in this case. Sometimes it looks like persistent SPK. Sometimes it looks like dry eye that doesn't respond the way we think it should. And so I think that's really challenging. And so if we're not testing things like corneal sensitivity, we might miss it. And I think that's a detriment to our patients. And so in any case, I'll leave you with this. As I said before, pick one, start using one, figure out where your gaps are, and then move to the other. And that's the hinge, right? Identify it, use it, and then realize that we're not just treating dry eye, we're treating a bigger problem. And I think it changes the conversation, it changes the education, changes the medical necessity. And that allows us to think about both of them logically. I hope this was helpful. Let me know what you think. I'll see you guys on the next video.